Okay. Okay, everybody. Welcome once again to the FRCS Mentor Wednesday teaching session. As always, we're very glad to have you all here, and we're very proud to have Walid Elnahal, one of our early mentors, who's working as in the young adult hips as a fellow there in the Royal Orthopaedic Birmingham Children's Centre. He's going to talk to you about young adult hips, and I'm really looking forward to this talk because young adult hips is often a very difficult topic, and it invariably does come up in the FRCS exams. Mastering this is something which I think will help you significantly when it comes to the exams. Without further ado, Walid, it's a real pleasure to have you here. Thank you.
Thank you, Shwan, for the introduction. As Shwan mentioned, the problem with young adult hip is that it's something not a lot of us do encounter during our rotations, whether you're a trainee or non-trainee. It's sort of a gray zone. It's between pediatrics. Most of us do encounter pediatrics, and most of us do encounter the older 60-plus-year-old patient who comes in with hip arthritis. But that gray zone, which is between sort of 16 and 50 years old, that's the part that a lot of us don't encounter. So there's plenty to talk about in that, but I'll sort of touch on the topics that are important, or from my point of view, at least I think are important for the exam. So these are the three topics I picked for today. Adult hip dysplasia, femoroacetabular impingement, and AVN of the hip. So I'll just want to, if you're happy to make this a bit interactive, then I think we can try to do that. This is an X-ray of a 23-year-old lady, hip pain on the right side for the past couple of years, mainly with activity. If anyone would volunteer, give us a comment about what they could identify on the X-ray and how they would assess that patient and manage accordingly. So thank you. That was very well put. So adult hip dysplasia is basically the same as hip dysplasia in pediatrics. It's either residual from the childhood period or unrecognized dysplasia from the childhood period. And the problem with it is that because we've got a shallow acetabulum, we've got inappropriate covering, then the forces on the acetabulum are not well distributed, and then patients then complain of pain because of the unequal distribution of forces, and that would then lead to arthritis. And particularly with adult hip dysplasia, there is a direct correlation and direct link between the onset of pain and the arthritis. It is thought that some studies showed that's around 5 years between the onset of symptoms and the start of arthritis. And as Dr. Metwelly very well sort of elaborated, the main two angles, there's plenty of angles and plenty of images and plenty of views you can get, but for the FRCS, at least from my point of view, I think that these are the two main angles that you would need to know, and these are the two angles that you can basically eyeball just through the X-ray and just pick up. So the lateral central edge angle less than 20 degrees, this indicates frank dysplasia. Between 20 and 24 is borderline. Acetabular index more than 10 degrees is dysplasia, and between 10 and 14 is borderline. And in a clinical setting, it's very important that any young adult presenting with pain, you would actually measure these angles. If you're using printouts, then you would need to measure them using rulers and protractors. If you're using a computer software, then you would need to use your computer software to measure these angles, because they could really sometimes fool you. There's the extrusion index, which we don't need to go through the details. Shenton line, most of us know the Shenton line from the trauma and the hip dislocation. It's basically a disruption of the line between the inferior border of the neck head with the superior pubic ramus. And in history taking, so this is a different type of patient from our 60-year-old patient who has frank pain affecting his day-to-day life. This is a more subtle presentation. One of the things I would be sort of wanting to mention to show the examiner that I'm aware of the natural history of this disease is ask the patient when these symptoms occurred. So more than 5 years of symptoms then starts to ring some bells, because that could then mean that arthritis has already started, and that totally changes the management. The effect on daily activities and hobbies, particularly the hobbies, most of these patients could be actually fine with simple tasks. If they have a sedentary job in an office, that might not be the problem. Their problems could be mainly in their hobbies. And that's the activity level and expectations, because some of them are quite active and their expectations might be a bit too unreal for the condition that they have. So that might need to be tailored according to their disease. Childhood hip problems. As I mentioned, some of these patients have had problems throughout childhood, and it's a very important thing to touch on, and whether or not they've had previous surgeries, that will definitely affect your decision making. And because dysplasia has a genetic prevalence and family history of hip problems as well. Examination, there'll be scars from previous surgeries. The gait, Trendelenburg gait or short-limbed gait. They would have abductor muscle weakness because it's a long-standing condition. Leg length discrepancy is very common, could be femoral, and in a lot of the cases, the difference is actually also in the tibial side, not just the femoral. Rotational profile is a key really in assessment of these patients. A lot of them have increased femoral anteversion, which is very important whether you are aiming for hip preservation or you're aiming for a hip replacement. So when we talk about management, there really is a very important factor that will determine our management. So before, what I would do in the exam, if I would put an X-ray like that, before jumping into management, part of my crucial assessment is to say, I would ask for further imaging, particularly an MRI scan, because it is the presence or absence of arthritis, even if very little, very subtle arthritis, that will dictate which direction I go. We have three options, basically: non-operative, a preservation option, and a hip replacement option. Non-operative, mainly for patients who have mild symptoms or asymptomatic, but the symptomatic patients who don't have arthritis, you could really argue against the option of non-operative treatment unless they refuse it, because the natural history of this disease is to progress to arthritis. So if the patient is aware of that and he doesn't want surgery and he has symptoms, then that's fine, as long as he knows that he is likely to develop arthritis within the next 5 to 6 years. So non-operative treatment for symptomatic, maybe not the best sort of option. Hip preservation, the determinant factor here is that that patient doesn't have arthritis, and hip replacement is our salvage procedure. And when we talk about hip preservation, the most commonly performed osteotomy is the Gans periacetabular osteotomy, known as the Bernese osteotomy also. There are different osteotomies. In Birmingham, for example, we use the Birmingham interlocking triple pelvic osteotomy. However, this is the more sort of common one. And I don't think we need to know much details about it for the FRCS exam, just that reorientation osteotomy, it's done through a single approach, anterior approach, and that preserves the integrity of the posterior column. And that's the whole idea of the periacetabular osteotomy, is preserving that posterior column. It does violate the triradiate cartilage. That's why it cannot be, it's not done in these skeletal mature. So in the list of osteotomies you would find in your pediatrics chapter talking about dysplasia in children, you will not find this osteotomy in one of them as one of the options available. So the results, originally Gans reported an 82% survivorship at 11 years and 60% at 20 years. The poor outcome, as would be expected, is hip arthritis and older age. And more or less, these results are reproducible. And initially, there was a high complication rate. The initial studies showed complications of up to 20%, but with better surgeon experience and more of these cases being done, the complication rate has gone down to 4 or 5%. So this is the topic of hip dysplasia, and it's really quite simple. And I don't think for the FRCS we you'll be probed to go much deeper than that. I think it's just basic knowledge, but it is a topic that I think is of importance for the exam. If you cannot recognize hip dysplasia, diagnose it, and at least direct the patient to the appropriate service, then that is a huge problem. Next, we'll talk about the second option, a hip replacement option. And this is a classical FRCs sort of question. And if someone else can volunteer, have a look at this X-ray and tell me what they're thinking of, what their concerns are regarding this patient and how they would address these concerns. What I would sort of say or start saying is that this is a complex case. It needs an arthroplasty surgeon, and preferably a senior arthroplasty surgeon, who has special interest in these types of cases. And it's very important to mention also pre-operative planning in these cases. I wouldn't go in with an X-ray alone. A CT scan is important. Look at where I have bone stock. Look at also a CT scanogram. Look at the leg length discrepancy. You can be fooled again by the leg length discrepancy. Although we know it has a high hip center, this could be compensated by the tibia, for example, and she might have differences in the tibial leg length. So all of that sort of needs to be put into consideration. And there's two main classifications you can look at. There's the Hartog-Lachidis classification system. This patient would be a type B, as Norman mentioned. And there's also the Crowley's classification, but it's a more complex one and involves measuring the pelvic height and the percentage of proximal displacement from the pelvic height. So I would then put the challenges I can see in that case and try to propose different solutions for these challenges. So the challenge number one is the high hip center and the insufficient coverage of the acetabulum. So that's on the acetabular side. It's also important to measure the challenges on the femoral side. We've got abnormal offset, we've got a valgus neck, we've got abnormal femoral version in most of these patients. Again, you would recognize that by examination, but take care that these are arthritic patients and you might not be able to do a proper rotational profile given their lack of rotation. So this is better elaborated in a CT scan. You would have a narrow canal, which is very common in these patients and could affect your choice of implant, depending on the size of the canal. And they have leg length discrepancy. Plus, if they've had previous surgeries, you've got scar tissue from previous surgery. So on the acetabulum, it's important that you plan it well with a CT. And in some centers, they would also go ahead and print out 3D planning using 3D printing printers to sort of look at the anatomy and look at and appreciate where the areas of bone stock are. And the aim is, as we mentioned, to restore the hip center. This increases the longevity because it has better bone stock, and it also reduces the forces across the acetabulum. And we have to reconstruct the acetabular defect. This could be done by bone grafts or by augments. On the femoral side, we mentioned there's problems with the version and the offset. Now, there's a variety of ways you can address the changes on the version of the offset. One of the options is using the modular stem. This is one of the stems that are used in these cases, called the SROM by Dupuy. You can use a cemented exeter, a small cemented exeter, which would you could then change the version accordingly. And as we know with the exeter, you have different options of offset. In some extreme cases, you go for custom-made implants. For the leg length discrepancy, you have to go in with a plan. How much leg length discrepancy do you have and how much do you want to correct, and whether or not you need a femoral osteotomy. In these cases where you need a femoral osteotomy, they would then do a subtrochanteric shortening osteotomy. And if there is a rotational deformity, then that would be corrected with the shortening. And as we mentioned, the narrow canal, you need to choose your implant based on the canal size, and you have to be aware of the risk of peripatetic fracture during the surgery. So that's that's how probably I would try to approach it. I would put the concerns and then put the solutions. And according to the case I have, if they want me to put which solution you would choose, I'd probably go for the simpler one. So if for this case, for example, leg length difference is probably not huge. Yes, on the acetabular side, we'll aim to restore the hip center. On the femur side, you can use a cemented exeter and probably not need a shortening osteotomy, because we're talking about 1.5 centimeters. More than 3 centimeters is when you would worry about the leg length difference and the sciatic nerve injury that could happen following the leg length difference, and then you would need a shortening osteotomy. Okay. Next, if we go to a third case, I think you did great, really, and we went through all the history. So basically, it's the history, more or less the history we spoke about in the sort of hip dysplasia. The onset of symptoms, when it happened, is important. Triggering factors is important in these patients because it's usually with certain sports, certain movements, sitting in deep flexion. Maybe stairs, because they also reflex the hip. Driving is one of the triggering factors because of the deep flexion. And usually it's affecting really hobbies more than daily activities, except in later cases. Expectations, which is very important, because if they are planning to go back to sports, then that is something that needs to be discussed and made clear, because unfortunately not all of them can go back to the same level of activities that they were in previously. Examination, really more or less a normal examination, other than the impingement tests being positive. Rotational profile is important. Some of these patients have femoral retroversion, a bit different from the dysplasia patients that we said they have femoral antiversion. These, you could have them either ways, but we see retroversion more commonly with these patients because the retroversion increases the impingement. And management, 1 of 3, non-operative management, but that includes activity, or that involves activity modification. So basically, this is where it's different from the management of dysplasia. So we know about the management of the dysplasia is that if you do leave it untreated and they are symptomatic, they would then progress to arthritis. But here, if with impingement, the link, there is a link, but it's a weaker link. So these patients, if they modify their activities and they no longer get the pain and they're no longer putting their hips in that impingement position, then there would be no need for surgery. And then there's the option of physiotherapy and surgery. And here, we usually, don't need to know much evidence, particularly in topics that are not really common. But with hip arthroscopy in particular, there's 2 national trials, and very, very big national trials that were done over the past 5 years, and the FATE trial and the FASHION trial. And it's always good to know about these national trials, because it is showing the examiner that you are up to date, you are attending the meetings, the orthopedic meetings, because they are mentioned in every sort of hip arthroscopy meeting done in this country, both of these trials. And we get updates almost in every year at the BHS or so on about these trials. So, and both of them more or less show the same, that whether the physiotherapy group or the arthroscopy group, patients with FAI, who had physiotherapy, they did improve in their outcome scores. The arthroscopy group did also improve, but the improvement in arthroscopy was better or more significant than the improvement in physiotherapy. So although the baseline in arthroscopy was less than the baseline in physiotherapy, the change or the improvement in arthroscopy was higher. So these are just 2 quick papers. I think they'd be good to quote, and we do mention them to any patient who is heading for hip arthroscopy. And there's now a non-arthroplasty hip registry. This is, I think, the 5th or 6th year now. not exactly sure, but this captures all hip preservation surgery, including hip arthroscopy. And this is also showing good outcomes for hip arthroscopy and improvement in the hip function scores. Now we get to the third topic, and perhaps the most important and more common topic in the exam. And this topic I really wanted to talk about, and I was thinking of putting it first because I was grilled for 5 minutes in my exam about this, and I was up to date, maybe not as up to date as I would have wanted to be back then, but they did go into details which I didn't think they would have gone into. So if someone would like to take the lead and look at this MRI scan and this brief history and tell us their thoughts. We'll try to go through them and go through the different procedures. And the problem with the vascular necrosis is there is no strong evidence to sort of advocate one treatment over the other. There's no consensus, and you can't really be wrong or right for choosing a particular option, particularly with the level of evidence that we have for each option, unfortunately. So quickly try to go through them. And this is basically what happened in my exam. I went through the options. I told them which option I'd pick, and I was asked how I would do it. So that's what I'll try to do today. So etiology, it's a long list of etiologies. This is just a snapshot of them. Trauma, probably the most common. Steroids and alcohol, that's the most common of the non-traumatic causes. And then you've got sickle cell, you've got chemotherapy, and so on. Pathophysiology, also particularly for the basic science, that with the blood supply of the femoral head is one of the very common questions in basic sciences. Not going to go through the details, but basically it's one of these four: either a trauma, direct interruption of the blood supply, or increased pressure inside the femoral head because of the cell hypertrophy or fat cell hypertrophy. This is one of the mechanisms thought to be caused by steroid use. Emboli, such as sickle cell or Casion's disease, and idiopathic. And some cases you just don't find a cause. Imaging, you'd usually need to mention a lateral view. And the case that I got in my Viva, there was really nothing to see on the AP view. And when I did mention lateral view, they did show me an X-ray of a lateral with a very, very subtle cyst on the lateral view. And that was basically the sort of clue of AVN. That and the fact that they had told me that the patient had chemotherapy a year before. So on the lateral view, you're looking for cystic changes or sclerosis or crescent sign. MRI, it's very important. That is positive before the radiographs. It shows you the location of the lesion, the size of the lesion, and the articular collapse. The location, size, and the collapse is basically what's going to guide our management here. You can mention bone scan. I'm not aware of a center that does it. You get a ring of cold area followed by a center of cold area followed by a ring of uptake, and some literature they call it the donut sign. Classification, there are plenty of classification systems, and really what's common between them all are two things. Number one, they all have poor inter-observer reliability. And number two, they all try to categorize the patients into pre-collapse and post-collapse. And FICAT is one of the most common we use. Steinberg is a modification of it. There's the ARCO classification, which is a more complex classification. It takes into consideration the size and the location. And there's the Japanese classification, takes the size into consideration. But more or less, we're talking about is there collapse or is there no collapse? And that's what would direct you: pre-collapse, hip preservation; post-collapse, then no hip preservation. Okay. Non-operative treatment. So non-operative treatment is for the small lesions and for the asymptomatic patients, and if surgery is contraindicated. Restricted weight bearing has not shown to be of any use in preventing collapse. So that's something you can also mention, that you're not going to restrict. Some patients, some would advocate to restrict them anyways, as that's not going to really, if that's not going to be of much harm to them. As you can see, while we talk about this, you always find that in every one of these topics, you'll find some evidence available for one thing and evidence that contradicts it on the other side, which what makes it quite difficult. Bisphosphonates, there's been recently a lot of talk about bisphosphonates and their use, but again, contradicting evidence, some showing it can prevent collapse and others showing no benefit. And like this paper, for example, in the American JBC, showing that they did not find any benefit of using zoledronate in stage 1 or stage 2 osteonecrosis. In the UK, there was a trial, or the MANTIS trial, which was meant to be a randomized control trial between bisphosphonates and placebo. And again, I always have the feeling that these national trials are good to mention in the exam. However, this trial fortunately was abandoned due to recruitment problems. And the recruitment problem with osteonecrosis is because patients usually present quite late after they've had collapse. So by the time they present, then they're not eligible to be included into the trial. And also putting in mind that osteonecrosis is a very wide group of patients. You've got patients with idiopathic osteonecrosis, or patients with reversible causes of osteonecrosis that have had steroids for a period of their life, then they're not on it anymore. But you've got unreversible causes, you've got sickle cell, you've got lupus. All of these, they continue to have the precipitating factor of their osteonecrosis. So it's difficult to conduct a study with this heterogeneous group of patients that, as I mentioned, usually present late. Other forms of medical treatment that you'll find in literature: statins, clexane, hyperbaric oxygen, vasodilators, iloprost. However, all the evidence is still weak for all of them. Now, the most common surgical procedure, and probably the one I would mention in my exam, just to try to avoid, again, you're free to pick whatever management you think is appropriate, or whatever management you are used to doing in your hospital. But I think my point of view in the exam, I would stick to the core decompression. Why? Because it's the most common procedure that is performed. And usually the question would then be, how would you perform it? I would perform it, first I'd look at the MRI scan, look at where the lesion is so that I could plan where my drill holes would be. I would put the patient on a traction table without applying traction, just on the traction table, so I can get good views of the hip. Instead of using one large drill, when this was originally described, it was described with a large drill, 9 millimeters or 10 millimeters to refine. But I would use multiple small drills, and the evidence has shown no difference in outcome between using one drill or multiple small drills. The only difference is you get less risk of fracture with multiple small drills. I would target the area of avascular necrosis with 1 or 2 or 3, depending on its size. What evidence do I have? Originally, when Fikar mentioned this treatment technique, he reported a 90% success in the pre-collapse phase. However, recent studies have shown less, so it goes down to 63% or so. Then there's another option that's used in this country called an X-Ream, if some of you are aware of it. It's more or less the same. It's a core decompression. You aim it at the lesion, and then you inject bone substitute. And the studies, which are sort of case series rather than level 1 studies, are quoting 80 to 90% success rate. And there's non-vascularized bone grafts, filling it with cortical autografts, and studies have shown better survivorship than just core decompression. There's vascularized bone grafts. We're taking a fibula with its nutrient artery and anastomosing it to the branch of a lateral circumflex. You'd need microsurgery for it. And studies that advocate for this are suggesting that it does have even better outcomes than the non-vascularized option. Then comes the femoral osteotomy, which if I were to mention, I would mention really briefly, and I would not really advocate for it. It does aim to offload the necrotic area. The choice of osteotomy would differ according to where the necrotic area is. Usually the necrotic area is anterolateral, so it's a valgus flexion osteotomy. And the studies are quoting 80 to 90% success. The main disadvantage here is why I would stay away from it in my exam setting, is because this might compromise your hip replacement later on. It's not going to prevent you definitely from doing a hip replacement, but will make it a challenging hip replacement. And usually in hip preservation surgery, one of the main things you think about is you think about the next surgery, because these are young patients. They're likely to require surgery again through their life. You doing an osteotomy now is a big undertaking for a patient that might then eventually require a hip replacement. Trapdoor procedure, again, has been even described in late stages, stage 3 or 4, involves a surgical hip dislocation, involves opening a trapdoor in the cartilage, removing the necrotic bone, and putting in bone graft in the necrotic area. And again, quoting success rate in 80% in stage 3, but these results are not reproduced in other centers. So just to see how, as an example of how my viva went in that particular topic, I sort of went through all of these options, including the medical options. Bisphosphonates, perhaps I wasn't really up to date, but I said there's no evidence that, it is of use, and which turned out to be what should have been, which is the case. Trapdoor procedure, surprisingly, that's where the discussion then went into the trapdoor procedure. And then we started talking about what is the safe surgical hip dislocation. And as I was describing the surgical hip, sort of safe dislocation of the hip, that's when the bell rang. And I think they were quite happy with the viva. Total hip replacement, this is your salvage procedure post-collapse. You could argue that it could be done from the start in cases with non-reversible etiology or a large size region. Historically, and this is where you could fall into this trap. If you've been reading some old literature or studying from some older textbooks, then it used to classically say that they have lower outcomes than hip replacement for osteoarthritis. Recent literature has not shown that. If anything, they have shown comparable results with total hip replacement for osteoarthritis. The difference really is not the cause, not the AVM. The difference is that these are a younger cohort of patients, and usually the younger cohorts of patients, they get more incidence of loosening or so on because of their activity level or so. But generally speaking, no, that it is comparable results to osteoarthritis for total hip replacement, with some exceptions for, depending on the etiology. So in sickle cell, generally they do worse because of their bone quality, and of renal disease also because of their bone quality. And that's about it, really. We can try to cover more topics in young adult hip in later sessions, but I think these 3 are the most common in the FRCs. Thank you.
Sorry, thank you very much. Quick question, please.
Yeah.
The safe surgical dislocation is the GANS operation.
Yes.
For the.
Yes.
Can you take us through quickly how is it done, please?
Yeah, so I don't have the slides now, but basically it's you start off with a posterior approach to the hip, and then you need to identify the vastus lateralis, and you need to identify the abductors and the GT, and then you do your osteotomy, a biplanar osteotomy into the GT, leaving the vastus intact and elevating the gluteus medius with your trochanteric osteotomy, leaving the gluteus minimus attached to the trochanter. And then that exposes the anterior hip, the capsule of the hip, where you do a Z-shaped osteotomy, and there you could do a Z or you could do a T. Z is the more common one, and then you dislocate the hip anteriorly, preserving all the posterior structures.
Thank you very much.
Thank you.
Thank you very much,
Thank you.
Walid. That's an excellent talk. And what I really liked was the part of the talk where you explained that these are not straightforward cases, and that in the exam, if you're presented one of these cases, don't just plow straight into I will do. Recognize that it's not a straightforward case. It requires a specific young hip expertise, and that these cases require consultation with someone who has more experience in these things, because as you've explained correctly, that the majority of us won't come across these young hip type cases as management, but as a regional referral. Yes, that's correct. Thank you very much. There are a couple of other questions. Would you do a hip preserving surgery for non-idiopathic AVN as well?
For non-idiopathic AVN, or do you mean idiopathic?
It's the question is non-idiopathic. I think
so. Yeah. So when you're doing a hip preservation surgery for AVN, you do aim to stop the precipitating factor if you can stop it. So alcohol you advise against, but there are things that you will not be able to stop. And the problem with AVN is that you're always put in this situation. You put a situation, you get a youngish patient who has either reversible or non-reversible cause of AVN, and you've got a surgery that doesn't give you a good outcome, and there's no strong evidence to advocate one surgery over the other. But at the same time, you cannot, as a hip surgeon, watch this patient just develop arthritis and leave him the way he is. So you basically opt in for a surgery, counseling the patient and telling him that we're going to do this surgery, the outcome is 60% or the outcome is 70%. And there is a chance of failure, and if that fails, then we're talking about a hip replacement. So yes, even when in all cases, whether it's idiopathic, non-idiopathic, yes, hip preservation surgery, providing there is no collapse. Once there is collapse, then I think the options are no longer valid.
And a question from me: if you have a patient who has progressed in their AVN and is deteriorated to the point where they need a joint replacement, your approach to the hip replacement would be different depending on what's the source of the AVN or cause of AVN? How would you?
So that's a good question, and surprisingly, I really haven't found a solid answer for that. I remember when I was they were talking about using uncemented rather than cemented stems because of the AVN, but I haven't seen any evidence for that. And the AVN is in the head, it's not in the stem, and it's not in the socket. So once you've removed the head, there's no logic that would say that one is better than the other. And from my sort of experience from where I work, it's what implant you use or what approach you use is patient based rather than a specific implant, particularly for it. What you use is what you go for, basically, rather than changing it because that patient has AVN. The only difference really is if you do hip resurfacings. If you do hip resurfacings, then that's something else. And yes, you could do hip resurfacings for patients with AVN, but there are concerns with that, big major concerns with that.
Okay, and another question from Vilas. Any timelines in terms of preservation surgery? How early to prioritize on waiting lists?
Pre-collapse, yeah, on waiting list. So these patients go ahead of the waiting list. If you find a pre-collapse patient, which you don't find a lot, and I was talking to the consultant I work with, basically over his sort of 10 years of practice in young adult hip, he's come around, about 10, 12 patients of these pre-collapse. So it's once a year that you see a patient like this who is actually a candidate for surgery. So yes, when you do pick them up, these patients are given priority within the next few weeks. Within 6 weeks, usually is ideally what we aim for, if not sooner. So even through COVID, I remember when we were not operating electively, we did pick up a patient, and we did do him despite the COVID restrictions in the hospital at that time. So yes, these are done in a more urgent case.
Thank you. If there's no more questions, we'll end the lecture part of this talk. Excellent talk, really. Very important topic. Really appreciate it. Thank you so much. And really well explained. You guys will have a chance to go over the YouTube video. We'll put it on our channel. But it's worth rereading this and going through the video because it is an important, these topics are very important in the exam. Thank you very much, everybody. If we'll stop the recorded part of our section, move on to the Viva section, please. We'll see you soon.